Hello and welcome to Better Living for Better Health. I'm Melody Nall, the Cancer Control Specialist with Kentucky Cancer Program. Our show today highlights a very important program in our area, hospice and hospice care. Hospice staff and volunteers help patients and their families and friends to focus on what's most important to them, allowing people to spend time together, share memories, say goodbyes, find peace, or care for one another. I'm pleased to welcome three guests today that are very knowledgeable and can teach all of us more about hospice and how to receive hospice services when that time comes in our lives. I have Dr. Troy Nelson with me today, and he is one of the medical directors with Lourdes Hospice. Welcome.
Thank you.
And I have Rita Lewis. She is the patient care coordinator with Lourdes Hospice. And Tim Kissel, and you are the hospice manager.
Right.
All with Lourdes Hospice.
Right.
Welcome to each of you. I'm so glad that you're here, and thanks for being here. Let's just get started because I have a feeling we're going to run out of time with our 30 minutes today. But give me a definition of hospice. What is it? What types of services are involved? Anybody?
It's a service for people with a life-limiting illness. A terminal diagnosis has been given, and perhaps they're to the point that they're seeking more comfort measures than curative. What we provide is a team of professionals that can assist patients and their families with spiritual, emotional, physical needs, based mainly in the home to keep people at home.
Okay, so a very holistic view.
Yes.
Not just the medicine. Who would be eligible for hospice? How about you?
It varies to all individuals. Again, as Rita pointed out, it's to anyone that has a life-limiting disease that statistically speaking, that if there is a greater than 50% chance that 6 months is or less is going to be the terminal illness, then they are deemed eligible. That may change to 1 year. And then then the course changes to being, instead of quantity of days, quality of days. So the focus is from the medical, emotional, spiritual, social work aspect. All aspects work to make each day as good as it can be for what the patient and the family is going through.
Right, right. In fact, I had the opportunity to hear you speak to some medical professionals, and I pulled out one of your quotes, and it says, "It's adding life to days," and I loved that quote. I think there's a misconception that hospice is just for cancer patients. And I know you've given kind of a broad, but could you give some maybe other specific examples of folks who could benefit from hospice?
Yes, it's anyone who has a life-limiting illness or injury, so it's much broader than just cancer. It could be someone with end-stage heart disease, respiratory illness, dementias, Alzheimer's, those kind of things. Many times it's those kind of patients who are no longer able to feed themselves, minister to their own activities of daily living. They're not able to bathe themselves, do those kind of things. So at any point when someone reaches that stage when you're looking at maybe if you've had heart disease and you've been in and out of the hospital and you no longer want to go back into the hospital, make those return trips, then hospice would be something you should consider, because we can provide that support in the home to keep the patient more comfortable and support the family through that. So it's any kind of illness that would be life-limiting.
Okay. How do the number of hospice patients in our areas compare to maybe the folks that are eligible? Are we at capacity, or is there room for more people to be added to the hospice program if they have a need?
We feel there's a lot of patients that we're not reaching, whether it's lack of knowledge about who can benefit from hospice or a multitude of reasons, but and you may be able to speak to this more as far as data that we the penetration rate is not what it should be for our area that we service, the 13 counties.
I think for the state of Kentucky, I think the last statistics we had was 2004, and it comes from the Kentucky Association of Hospice and Palliative Care. The penetration rate for Kentucky is about 31%, which is a little bit below the national average. And so in our area that Lourdes serves in western Kentucky, our rate is about 23%. So there are many patients out there either through lack of knowledge of hospice or other barriers that they have, thinking that possibly hospice is giving up hope and those kind of things for whatever reason, needing more education for the community related to it. There is many more patients that we could be serving or feel like we should be serving than what we currently are.
Why do you think that patients aren't coming into the program? Is there something that we could do? I know today our program, I hope, will be an education to the community so that people know more about it and can at least ask questions about hospice. But do you have other ideas of how we could get more folks in?
Well, I think a lot of this goes with even the myths of medicine that we may or may not touch on when discussing pain management for hospice that you even see in today's television shows that are very popular, that give the patient and families a misconception about how medical care is delivered in the U.S. To also think that there is still, we come from a real rural area. I was born and raised in West Kentucky and in a very rural area of this area. So knowing that there is a lot of tradition about what goes on in families and how we take care of our own, and we don't need that extra help, and too proud to ask for that, reach out for that hand or ask for that hand to help. Then as a professional in the community as well, that a lot of colleagues don't realize that they may be extremely knowledgeable on how to take care of the medical aspect. As a hospice director, I still run a internal medicine practice, and I still refer to hospice when the need arises. Now, why would I do that? Because the services are so much more than what a physician can give, that you've got so much extra support. You've got even a year that the family can have counseling and support from hospice after a year after their loved one has passed on. So there is the lack of education even in the medical community of we all are taught how to take care of acute illnesses, and no one ever likes to give up.
Right.
And because we've had to compete to get to where we're at, so we feel that to lose at not making someone better is hard. So it takes some adjustment from a professional standpoint that it isn't losing, that it is actually gaining better. And part of it is the American Society of Healthcare, how we've done great at mortality, but we haven't done much for morbidity as far as decreasing that. And where hospice comes in is where you start kind of trying to make those days better.
Yeah, and I think that's just a wonderful point.
So we really want to see hospice as a message of hope. When you're not looking at that physical cure, there's all kinds of other cures that you can do in terms of the emotional and psychological, the healing that can occur with that Dr. Nelson talked about. I think is so very important. And so I think if people would know that message, that what we want to do is improve the quality of life, the remaining quality of life, and help people manage their physical symptoms, but also those other things. I think most people don't, if you talk to them, don't really fear dying, but I think there's a real fear of being a burden on their family, of dying in pain or being alone. And so I think hospice really helps alleviate those things and give the patient and family opportunity to do those things. So if that message could get out,
Yeah.
then I think more people would
You just said
use
it beautifully.
Okay, thank
And
you.
awareness, just awareness, people, that it's okay to talk about it, that it's okay to discuss it. If your physician hasn't brought it up, that's okay to ask the question, hey, what about hospice? Is that
Well,
something I should consider? It's just feared. People
Yeah.
are afraid to talk about it.
Yeah, that leads to the next question, which I think you've already seen them, but who should make the decision about when to enter a hospice? Can it be the family or the patient, or is it always physician driven, and how is that decision made?
Anyone can call. Anybody in the community can call about information from hospice and make a referral. We do have to have a conversation with their physicians to make sure that they are appropriate, that they fit the hospice criteria. We would go and do an assessment of a patient, speak to them, explain what our program has to offer, and make that decision together as a team, the patient, the physician, and hospice, if they're going to be admitted into the program.
Okay.
And I think that this is important too, because this builds on getting a misconception of hospice. If you meet a patient for the first time in 48 hours, you can't build that bond.
Yeah.
Or 1 or 2 weeks, you can't build that bond with the family. There's still a lot of learning going on, a lot of adjustments going on. So it makes it very difficult to see the true benefit of what hospice is about. When people ask me of when's the right time to refer to hospice, is whenever that you're going to get that full 6 months and a day extra, that you had to file extra, because the myth is that if you live past 6 months, that you automatically get removed from hospice, and that's not true.
That's not true.
If you still need the services, you can remain for as long as you continue to need services. The other myth is once you're enrolled in hospice, you'll never get better. We have discharged patients that did get better just because of the holistic approach and went back into the regular medical community, and then know that we're there if they ever need us again.
Right. I think what you're talking about is so important, because I can think about when family members are facing the issue of losing someone, there's so many steps that they go through, and to have an opportunity to work with professionals and volunteers that can help them through the process. Emotions are so raw, when you finally have that realization that I am going to lose a loved one, but to have someone walk that journey with you, I just think that's tremendous, and being able to have that. As far as the admission process, can we cover that just briefly? What you mentioned an assessment.
A referral is made to our office. With that, we speak with the family, the patient, explain our services, give them the gamut of what we can provide. The physician does have to agree that the patient is appropriate within the guidelines of a terminal diagnosis, expected to live maybe 6 months or less if it follows its normal course. And as Troy said, we have many patients in our program longer than that. At that point, a nurse would go out and do an assessment of the patient. We try to build a plan of care around that patient personally for their needs, set up any medical equipment that might be needed in their home to help provide the care, order any medications and things that are going to be appropriate for comfort measures to take care of them. And then there's the wonderful paperwork that has to be signed. But
Always paperwork.
right. And then with that, visits are scheduled by all of the disciplines, assessed for needs of a volunteer, and all the services are set up on a schedule then.
Okay, so that's when the team really comes into play,
Yes.
and the patient and the family gets to meet everyone that's involved.
Right.
Okay. We're going to take a short break, and we'll be right back. Welcome back, and I'd like to once again mention that we have Drs. Troy Nelson, Rita Lewis, and Tim Kissel here with us today, and we're discussing hospice. The next question that I have is, who pays for hospice care? How is that covered?
Well, there's several ways that it's covered. There's the hospice Medicare benefit, which people who are eligible for Medicare can choose to elect that benefit.
And what age would that start?
Well, it would be 65,
Okay.
or someone who has a disability and qualifies for Medicare
Okay.
prior to that. Then also Medicaid kind of mirrors the hospice Medicare benefit and also covers hospice services. And so with that, they're provided everything they need to control their anything associated with their terminal diagnosis is covered under that. Then also private insurances, many of them have also the same kind of a contract that they follow that mirrors the Medicare benefit.
Okay.
For someone who doesn't have any insurance or anything like that, then we usually do a financial assessment to try to see what the patient or family is able to pay in regards to the care. And if someone's unable to, then they can qualify for charity care that can be done through our foundation.
Okay.
But they have to meet that. They have to meet those guidelines and have that financial assessment done prior to that.
Okay. So really, there's an opportunity for anyone who needs this care
Right.
to receive it.
Exactly.
Yes.
So if someone thinks, well, I can't afford, they should not hesitate to call, because they could have some help and assistance
That's
with
right.
this as well.
There's many avenues to get some
Great.
payment for it.
Great. You were talking about the home-based care and doing the assessment and maybe bringing in some of the equipment. I know some of the questions that come up, if someone has a small family and they may think, well, we don't have enough people to care for our loved ones. Are there criteria for how many family members to care for, or what types of changes in the home may be necessary if someone wants to have hospice care?
Well, one of the requirements is that they have to have a caregiver. A lot of our patients on the front end can still live independently and don't need help, but they have to have a plan in place that when they can't care for themselves anymore, there's a caregiver. To assist that caregiver, we can provide volunteer support for some respite. We do help people seek sitters. We don't provide sitters through hospice, but we'll help the family to attain those, give them information to maybe get that in place. Medical equipment is pretty much anything they need to manage, whether it's a hospital bed, wheelchair, whatever, that's going to make it easier for the family to be able to manage the patient. And then providing medications that are symptom-related medicines that they need to be comfortable and be managed at home.
And also the home doesn't just include a private residence. It can be a nursing home or assisted living facility.
Oh, okay.
And so someone in a nursing home can qualify, and that's considered their home.
their home.
They're a resident
Right.
there. And so what we attempt to do is provide support to the patient and family and to the nursing home staff to better meet the patient's needs in the nursing facility.
Okay.
So we do quite a few visits there. Into the
There's
nursing
actually 4 levels of care, and we maybe should mention that. The majority of our patients are provided in the home or the nursing home, but the levels of care are the routine home care, which would include those folks. We have an inpatient level of care if a patient needs to be into the hospital for symptom management, or if they're acute and are admitted in the hospital, there is that level of care. That's usually short-term. Respite care is something that is provided in 5-day stays. If a family needs a break or has to take a vacation, has another illness in their family, we can do a respite 5-day stay. And then, help me out.
Continuous
care would be, in crisis, we would provide more than just the routine visits, up to 8 hours a day or more, depending on the need at the bedside.
Wow.
So the real focus is to try to ascertain on that admission, with the patient and the family being the most important part of the team, obviously, which I don't know if we've ever stated all the members of the team, but of course it's the patient's attending physician, our medical directors, the nursing staff, social workers, chaplain, bereavement coordinator, and volunteers that we have, personal care aides that can help with bathing and personal care and those kind of a thing. So with that support, many times that's enough to help the patient be able to remain at home. But if they know they don't have family, they don't have caregivers, then we try to establish a plan up front, what they want to do when they get to the point where we deem that they're unsafe to be at home by themselves. And that could be admission to one of the nursing homes that we have a contract with, or they're going to move in with a family member or a friend, or someone's going to move in with them. So we try to address that up front and have that conversation with them early on.
So while they're still feeling well and taking care of themselves, they're able to help make decisions about themselves.
Right.
And so much more the need to get earlier referrals so that we have that time to
Yeah.
get plans made with people and get relationships, you know, established with the team members.
Right, right. I know you can get very attached to patients as well during this time.
Yeah.
I know another component of hospice care is pain management. Dr. Nelson, if you would maybe give us an idea of what is involved with pain management during hospice care.
Well, pain management basically is just whatever it takes to get the patient under control. I mean, whether it is things that we can utilize at home. Pain has 4 different kind of arms that needs to kind of be assessed and treated, whether it's somatic pain, neuropathic pain, neuropathy, and bone pain, types of different issues. Knowing what types of problems that they are having and being able to develop not only just the pain part of the therapy, but adjuncts that would go like the anxiety, depression, if things that the pain medications causing the patient to be too sedated, using drugs that will increase their alertness like Ritalin to give them more time to spend with their family but control their pain. Pain has a lot of myths that are just even used. I mean, the one that I can remember was on a TV show on ER when Dr. Green, a patient was dying and was in agony and pain, and the family's begging him to give morphine to this patient. Dr. Green states that no, you know, he's already got too much, another dose will kill him. Well, that's furthest from the truth, just because I even recently used quantities of certain narcotics that would have given to people that had not been used to taking narcotics would have probably would have been enough to kill a large
Right.
portion of the hospital, just because, and that patient was still alive, breathing well, and comfortable
Not in
to the last minutes of his life. And so whatever it takes, even if it means that I have to be at bedside to adjust it or come in, then that's what it takes. So just to get that level of control, and that's kind of the commitment that all of us at the hospice have.
Because if somebody's in pain, their life, their quality of life is much less. And also for the family members, because when you have a loved one that's hurting, you can't function and do well with that. So
Right.
there are many different avenues to control that pain, and that's decided upon with the physician. As far as the family, we talked about, I think you mentioned a bereavement program and volunteers.
Right.
Could you maybe discuss what is provided for the family and what they can benefit from this program?
Well, after the patient's death, we have a bereavement coordinator who makes contact with the family. Many times they go to the visitation, and then they're available to do home visits afterwards to help the survivors of the loved one to be able to work through the grief process, to know what's normal reaction related to the experience they're having after their loved one's death. So it's just helpful to know that some of the things they're feeling are normal, you know, and so that's available. We send out mailings, booklets that talk about the grieving process on a schedule after the death, routine schedule. We have a quarterly memorial service that we invite the family to come back and remember their loved one, and that's done annually after the death, I guess, for each family, and for our staff. Our staff become very attached
Sure.
to the patients also, and so that's another way for them to go back and think about the interrelations they've had with the family and the patient that we'd had. And then we have grief support groups that meet on a regular basis. In Paducah, I think we meet every Monday afternoon at 2.
And those are for people in the community as well, not just hospice patients. I'd like
Yeah.
for people to know that
Right.
they're welcome welcome to come to that.
That meeting is open.
Yes.
It's open to anyone. Mayfield, and we do it at the Mayfield office every third
Every third Tuesday
Tuesday.
at 6 in the evening.
6 in the evening. And then we schedule different grief support groups throughout the year that we
Workshops.
advertise, workshops and stuff that we advertise, and those are open to the community also.
Okay.
So
You guys do amazing work.
I would like to say something about the volunteer program. Susan Mason manages our volunteers and does an excellent job. And just a thank you to the people in the community that serve as our volunteers, that give of their time and go out. And there's so many different aspects in which you can serve as a volunteer if you don't want to do, you know, direct bedside care. There's running errands for patients, there's delivering things for patients, phone calls, following up with the bereavement phone calls, working in our office. There's a multitude of things that folks can do should they choose to volunteer. And we've got, you know, we've just got some great people on board that really make a difference to our patients. They love us and they appreciate our services, but their volunteers are oftentimes their favorite people.
They become very attached.
That's true.
Yeah.
So,
I knew this was going to happen. We're coming to a close here, but I would like to give each of you an opportunity to make a closing statement about hospice and what you would like the community to know about this program. Can we start with you, Dr. Nelson?
Well, the one thing is to just, if there's any question whatsoever at any time of diagnosis, it never hurts to ask. The biggest answer will be not at this time, and we'll be there if we need to. We encourage that their physician be always involved. Some physicians choose to be more involved than others, and we encourage that. Sometimes that's a myth. It's not. Because it's named Lourdes Hospice, some that choose Baptist, Western Baptist, believe that they can't have that type of care over at the other sister hospital. So it's available full circle.
Around the area. Rita, quickly?
I guess just for people not to be afraid to ask, anytime you're given a life-limiting illness, to seek out all the information you can then of all the treatment options, what's the next level, the next step, so that people can make an educated decision and decide when it might be appropriate to move into that next level of care.
Thanks. Tim?
And I think I'll just close with saying that we're getting ready to celebrate our 25th anniversary of hospice. We started in 1981, and so it's for the people who's been involved with hospice. We were looking at photos of old team members in the past. I think it's been a real privilege for us to be able to be a part of these people, such a crucial part of their lives, and thank the community for the support that we've had from them over the past 25 years, and just know that we're there to help if you need us. And if anyone needs to make a referral number, can I give the number?
Sure, absolutely.
It's 415-3636.
Okay. We'll have that on the television right at the end of our program as well.
Okay.
Thank you so
Thank you.
much. I appreciate
Thank
it.
you
you
for
for
the
having us.
opportunity.
I
Great.
think we could talk another hour and still not get finished.
Certainly.
But I'll see you next time on Better Living for Better Health.